This prediction is, in one sense, the simplest and most foundational in this entire collection, and in another sense, one of the most disruptive. The idea that specific foods and dietary patterns should be prescribed and reimbursed as clinical interventions is not new. Hippocrates is credited with some version of it. What is new is the institutional infrastructure beginning to form around the concept and the economic modeling that is making it impossible for healthcare systems to continue ignoring it. The arithmetic of diet-related disease is straightforward and alarming. In the United States, approximately 60% of adults have at least one diet-related chronic condition: type 2 diabetes, cardiovascular disease, obesity-related metabolic syndrome, certain cancers. These conditions collectively account for roughly 75% of healthcare spending. The food system that produces this burden of disease is subsidized by the same federal government that pays for the healthcare costs of managing it. This is, at minimum, an incoherence. The economic case for intervening earlier and differently is not complicated. The evidence for specific dietary interventions is stronger than many clinicians appreciate. The Prescribes trial demonstrated that a Mediterranean diet supplemented with olive oil or nuts reduced cardiovascular events by approximately 30% compared to a low-fat diet, an effect size comparable to many pharmaceutical interventions achieved with food. Prescription programs in the United States, where healthcare providers subsidize fruit and vegetable purchases for patients with diet-related conditions, have demonstrated measurable reductions in HbA1c in diabetic patients and reduced hospitalizations. Medicare's 2022 inclusion of medically tailored meals for high-risk post-discharge patients was a landmark institutional precedent. The resistance to formal reimbursement of dietary intervention has historically come from multiple directions simultaneously. The insurance industry does not naturally reimburse interventions whose benefits accrue over years or decades rather than within a benefit year. The medical profession, not extensively trained in nutrition, has been reluctant to prescribe in a domain where clinical confidence is low. The food industry has actively lobbied against dietary guidelines that would reduce consumption of their products. What is shifting is the economic modeling. When longitudinal studies demonstrate that a few $100s invested in produce prescriptions and dietary counseling reduces downstream hospitalizations costing tens of thousands of dollars, the actuarial argument becomes very difficult to defeat. Healthcare systems that operate on value-based care models, where they bear the financial risk of patient outcomes over time, have a structural incentive to invest in prevention that fee-for-service systems do not. The implication for dietetic practice is significant. Nutritionists and dietitians moving from voluntary wellness consultants to prescribing clinicians embedded in care teams is a meaningful professional transformation. The food industry's eventual involvement in medically tailored meal programs, for better or worse, will also reshape how food is manufactured and marketed. This is not a niche development. It is a quiet restructuring of a major intersection between culture, medicine, and economics.